Good afternoon, everyone. It's so great to see you all here today. My name is Ryan Lang. I'm Chief Resident of the General Preventive Medicine Residency Program here at Johns Hopkins Bloomberg School of Public Health. And welcome to the annual J. Douglas Colman Grand Rounds Lecture. Our annual Grand Rounds honors the public service legacy of J. Douglas Colman, who created Baltimore's first nonprofit health service plan. Dr. Russell Nelson, President Emeritus of the Johns Hopkins Hospital and a longtime friend of Mr. Colman, established this lecture in 1974. And we are very honored today to host Miss Jane Lamott, the daughter of the late Mr. Colman, as well as her sister-in-law, Nancy Lamott. Thank you so much for being here. We are also delighted today to have Dr. Letitia Gerasa, the newly appointed Baltimore City Health Commissioner, as our special guest today. Please stand. And this program is also being live streamed. And if you are watching this via our live webcast, please follow along on Twitter using the hashtag SurgeonGeneralJHSPH. And at this time, I'd like to invite Dean Ellen MacKenzie to give us our introduction of our guest speaker.
Well, thanks very much, Ryan, and good afternoon to everybody, and a special warm welcome to Dr. Gerasa for joining us. It's a pleasure to have you here. Let me begin by adding my gratitude to all that Mr. Colman has did for the Baltimore community, and it's a real honor for us to have the opportunity to recognize his contributions and to have his family join us here today. I think Mr. Colman would be very pleased with our choice of this year's speaker, our Grand Rounds lecturer, Dr. Jerome Adams. Dr. Adams is Surgeon General of the United States and is the 20th person to hold this job since the first holder was appointed nearly 150 years ago. He holds the rank of Vice Admiral in the U.S. Public Health Service Commission Corps. In this capacity, he oversees the operations of approximately 6,500 uniformed health officers who serve in nearly 800 locations around the country. And they promote, protect, and advance the health and safety of our nation. As the nation's doctor, his mission is to enhance the health of the American people. Better health through better partnerships is his motto, and it underscores his commitment to strengthening relationships with all members of the health community and forging new partnerships with members from business, faith, education, public safety, and national security communities. He has created several initiatives to tackle our nation's most pressing health issues during his tenure as Surgeon General, including the opioid epidemic, oral health, and the links between community health and both economic prosperity and national security. In response to the opioid epidemic in particular, Dr. Adams issued the first Surgeon General's advisory in 13 years, urging more Americans to carry naloxone, the FDA-approved medication that can reverse the effects of an opioid overdose. He also released the report Facing Addiction in America, the Surgeon General's Spotlight on Opioids, and a digital postcard calling for a cultural shift in the way Americans think about, talk about, and respond to the opioid crisis. And just earlier this year, he called on physicians to reevaluate their prescribing habits and take a more proactive role in helping patients struggle with opioid use disorder. Dr. Adams is more broadly focused on building a culture of health and prevention in all sectors. As part of these efforts, he is compiling the available evidence and best practices, documenting the connection between the private sector, investments, and public policies which promote healthy communities and subsequent measures of business and community prosperity. Dr. Adams received his bachelor's degree in both biochemistry and psychology right here in Maryland at UMBC, an MPH degree from the University of California at Berkeley, and a medical degree from Indiana University. He has been a leader in numerous professional societies, including the American Medical Association, the Indiana State Medical Association, and the Indiana Society of Anesthesiologists. Dr. Adams is also former health commissioner of Indiana, where he led the state's response to Ebola, Zika, and the largest ever HIV outbreak in the US related to injection drug use. I am personally thrilled to have Dr. Adams with us here today and very eager to hear his remarks to us. Dr. Adams.
Well, good afternoon, everyone.
Good afternoon.
Wow, thank you, Dean MacKenzie, for that wonderful intro, and I apologize to the rest of you. My mother sometimes sneaks in an introduction, and that's the one Dean MacKenzie got, the one that my mother wrote. And so it was a little long, but I greatly appreciate you acknowledging a lot of the work I've done. I've had a varied path that in many ways started right here in the city of Baltimore and on the streets around us. I worked down the street at UMAB in the labs there, and have been to the hospitals up here. My nephew was up at Johns Hopkins just a few weeks ago because of the asthma that he's suffering, and the fact that it's difficult for him to receive the care that he needs in rural Southern Maryland, where we grew up. So we can talk about that, but again, it's good to be back home. Thank you, Ryan, so much for helping make this happen. Dr. DeRaza, thank you for being here. Again, I'm a health officer myself, and I don't say former because we're a family, we're a tight-knit family, and we all try to lift each other up, and it's so great that you're here today. And to the Colman family, you all are just wonderful people, and I like to consider myself a good reader of people and of character, and I already feel like I'm one of the family. So invite me sometime for a barbecue next time, and I'll show up. For those of you in the audience who may be unfamiliar with what the Surgeon General actually does, I'll start off by giving you a little primer. And some of you who know what I do may find that as a surprise, but I've been in medical audiences and public health audiences, and a lot of folks still have no clue what the Surgeon General actually does other than sit in a room and write warnings on the side of cigarette boxes all day long, which is part of my job, but it's not all that I do. First of all, I am not the Attorney General, and thank you for not introducing me as the Attorney General, because I've been at medical conferences where doctors have introduced me as the Attorney General. Don't want to be that guy. Do not want to be that guy. Didn't sign up for that job. Not the Attorney General. Second, to the untrained eye, I may appear to be an airline pilot, but you guys don't want me anywhere near the cockpit of a plane. Dennis is actually worried. Where's Dennis? Dennis is my aide, and when we go to the airport, it's funny, we've had frequent confrontations with people because they think I work for the airlines. We had a lady who got really frustrated with me because she was asking me where her gate was, and I literally didn't know where her gate was, and she was frustrated that this person who clearly works for the airlines is not trying to help me. I've been asked for peanuts and headphones on the plane before, and it's to the point now where I usually I get them. I know where they are on the plane now. I know where they are, but not a pilot. And finally, interestingly enough, I'm neither a surgeon nor a general. I'm actually an anesthesiologist, and I still practice about a day a month at Walter Reed in Bethesda. That was very important to me. And I'm a vice admiral. So the Public Health Service was founded over 150 years ago. And interestingly enough, a lot of what we did was work closely with the Navy to inspect ships and seamen as they came into port to make sure they weren't importing diseases like measles. And I never, ever thought that as Surgeon General of the United States, one of the biggest issues I'd be dealing with is measles. Unfortunately, I have to end early because at 1 o'clock, we're going to be on a phone call with the White House talking about the news that just came out that this outbreak now surpassed the largest outbreak that we've had since measles was declared eliminated from the United States. But I wear this uniform as a Vice Admiral of the United States Public Health Service Commission Corps. We got a couple officers in the crowd. Please stand up. Kim, are you here too, Smith? Thank you all. thank you all for your service, and really want you all to think about the possibility of using your skill set and wearing a uniform one day, because there's a lot of overlap between what you're learning about and what you want to do and what we do. The Commissioned Corps works along with the Air Force, the Army, and the Navy, and we've got officers all across the country and the world whose mission is to protect, promote, and advance America's health. Commissioned Corps was the only uniformed service that provided medical care during the last Ebola outbreak. We've responded to wildfires. I actually deployed to Puerto Rico after the hurricanes that happened there a little while ago. But my most visible role, and the one that you all know the most about, is serving as the nation's doctor. And in that role, I'm focused on promoting health, preventing disease, and leading with the science. So what's interesting is everyone wants me to be the champion for their cause. Every day there's a line of people outside my door who want to come in and say, we want you to make diabetes your top priority. Actually, we want you to make type 1 diabetes and not type 2 diabetes your number one priority. We want you to make opioid recovery your top priority. No, the problem is that's gone too far. We want you to make chronic pain management your top priority so that more people can have access to opioids. And it's really challenging to try to figure out what you're going to focus on, what's the biggest problem, where you're going to have the largest impact. And so what's interesting to me, and has occurred to me during my career in public health, is the what hasn't changed in my lifetime and in most of your lifetimes. Eat better, move more, get sleep, don't smoke. Anyone not know that? Anyone needed to pay Johns Hopkins thousands of dollars to learn that? No. The what hasn't changed. What's the challenge is how. How do you change behaviors? How do you communicate to people in a way that encourages them to do something which they aren't doing and aren't inclined to do? And so my priorities are in three main cross-cutting areas. Number one is addressing substance misuse, because I think we have a tremendous opportunity to not just look at the downstream effects of substance misuse, but to really look at what upstream caused substance misuse. The lack of health and wellness in our communities that leads to anxiety and depression, that leads to adverse childhood experiences, that leads people to self-medicate with cigarettes, with alcohol, with opioids, with methamphetamines, or what have you. And I think if we can really grasp this opportunity that we have, and it's strange to hear the opioid epidemic called an opportunity, but it is. There have been many people fighting for their entire lives to raise up the plight of folks right here in Baltimore suffering from substance misuse, and no one wanted to hear it on a policy level. Now everyone's talking about it. And so I think there's a great opportunity, and again, under that umbrella, I'm really focusing in particular on, of course, tobacco, but really the vaping epidemic that's hitting our country, vaping and e-cigarettes. Marijuana is very concerning to me, and I hope we have a little bit of time to talk about that, because I think we have to have the courage to have a more nuanced discussion about marijuana, not a all good or all bad. And right now, everyone wants to talk about marijuana in headlines and in tweets, and not really have that deep dive and talk about the concerns that I have in regards to young people and developing brains being exposed to marijuana, in regards to pregnant women who are using marijuana at increasing rates, and the effects that that could have on the developing fetus. My second priority is improving the health of communities and making the link between investments in health and resulting economic prosperity. And I'm going to dive a little bit into that in a bit so you'll understand why. And third is raising awareness of the link between our nation's health and its national security. And why am I tackling both of those two issues? Well, again, it's not the what, it's the how. And when you look at what people vote on in this country, you know what they don't vote on? They don't vote on health. And that's whether you're Democrat or Republican, black or white, rich or poor, rural or urban. And that's not Jerome Adams saying that. You can look at Gallup polls. People do not vote on health. The number one issue that people vote on in all of those categories consistently is jobs in the economy. So if we can talk about health in a way that shows people that it will allow them to get good paying jobs and support their families, then they'll be more likely to invest in health. Number two issue people vote on is safety and security. And no matter which side of the discussion you're on, people have different ways of getting there, but folks are concerned about keeping their families safe, both on a national level and on a very local level. And any psychology majors or psychiatrists in the room? The truth is, there's nothing really innovative about this discussion. It really is just Maslow's hierarchy. Anyone heard of Maslow's hierarchy? It's about what we reflect in our lives, and we take care of our basic needs first. We take care of our ability to provide for ourselves, food, clothing, etc. And we do that in America by having a job. And number two, we take care of making sure we and our families are safe. And way at the far end of Maslow's hierarchy, meaning lowest priority, is this idea called self-actualization. And self-actualization is being the best you that you can be. And it's very important, but it's not as ranked as highly as taking care of your basic needs, as being safe and secure. And self-actualization, those are our New Year's resolutions. That's public health. That's all the things that, hey, you know, when I get done with, once I get a job, and once I make sure we're safe, and once I find love, because that's number 3 on Maslow's hierarchy, and once I do all these other things, then I'll get around to quitting smoking. Then I'll get around to exercising more and going to the gym. Then I'll get around to going on that diet. And so we just have to understand what motivates people and then frame what we're selling in a way that they're more willing to buy it. We in public health and in medicine, and I hate to say this to this crowd because I don't want to discourage you all. I don't want you to run me out of the room. But we can be pretty arrogant. We like to stand in front of podiums like this and tell people that we know what's best for you. And by golly, you better do it because I've got this paper that says that this is why you need to do it. We do a very poor job of actually going into communities, listening to people, finding out what their needs are. Someone's not going to be physically active if they're worried about the safety around them. My kids live in a nice neighborhood. I can send my kids to go out and exercise. I can say, go outside and play. And that's all it takes to get my kids to be physically active. The will, go outside and play. Here in Baltimore, you can send your kids outside, they may get hit by a car because there aren't complete streets. They may get shot in a drive-by. They may get approached by a drug dealer. There are so many reasons and barriers that exist in their lives that we don't think about because we may not come from those worlds. And so it's important from a public health point of view that we really start to think about how we communicate and how we talk to people in a way that changes behavior. So that's why I picked the priorities that I picked. Shocking statistic I want to hit with you all very quickly in regards to my health and national security priority. This is one of those did you know? This is one of those tweets. 70% of our 18 to 24-year-olds in this country are ineligible for military service right now. Ineligible because they can't pass the physical, can't meet the educational requirements, or have a criminal background record. So our nation's poor health, the things you're trying to address, aren't just a matter of cardiovascular disease or cancer or addiction 20, 30 years down the road. We are literally a less safe country right now because we're an unhealthy country. And what do people vote on? They vote on safety and security. So if you want to create a healthier country, you need to understand that link, and we need to do a better job of partnering with our uniformed officers and with our people in communities, with our police officers, in order to make that point and to show them how we can get them to where they want to be. My guiding principle across all of my priorities is better health through better partnerships, because throughout my career in public health, I've found that we can only change our collective futures together. We do a good job of having meetings like this, where everyone's already on the same page, and we applaud wildly when the talk is done. But the fact is, all I'm telling you all is things you already know and things you already you want to hear. But who have we really brought into the conversation that is a mind that we need to change, that is a policy influencer, that's someone who can actually help us take our goals beyond the people in this room and turn it into real outcomes in the community? So better health through better partnerships is what I adopted in my model. And no one knows the importance of teamwork better than public health professionals. So again, really glad that I have the opportunity to talk to you all today. I'm going to talk a little bit about the opioid epidemic because I think it epitomizes the need for better health through better partnerships. An estimated 2.1 million people in this country struggle with opioid use disorder. Our family, our neighbors, our friends, statistically speaking, some of you all in this room either have opioid use disorder right now or recovering from opioid use disorder. And that is just, that's not to say that you're bad people. That's not to try to put you on the spot. That's because we need to recognize that the face of people suffering from opioid use disorder is all around you. Look around the room. We're the faces of opioid use disorder. And for me and my family, this crisis isn't just pressing, it's very personal. Some of you have heard me tell my story. My own little brother, Philip, is in a Maryland prison right now. He stole $200 from a vacated property to support his addiction and got a 10-year prison sentence. And I share my family struggle for a couple of reasons. Number one, it costs about $150 to $200 a day to incarcerate someone. So even if you don't care one iota about my brother or me, or if you think he deserves that sentence, that's all well and good. But my question to you is, at $150 to $200 a day times 5 years, let's say he gets paroled in 5 years, you all are going to be paying upwards of $500,000 to incarcerate him versus $5,000 for a diversion program, versus $500 for him to have seen a psychiatrist or a psychologist so that he could get his anxiety and depression treated, versus $50 for a community program that would have put him around people who could have had a positive influence in his life versus people who led him down the pathway of addiction. The other reason I share this story is because it illustrates that addiction can happen to anyone. We like to think that people who suffer from addiction are those people who are a couple blocks over in Baltimore, who come from disadvantaged backgrounds, and and there's a reason why that happened to them, and a lot of it starts with them. Well, you know what? My parents managed to raise a Surgeon General, so I think they did okay. That's just me, but I think they did okay. But they also raised my brother, who is in prison right now suffering from substance use disorder. So addiction really can happen to anyone, any family, and we need to share our stories because that's the only way we're going to overcome stigma. One of the questions I most get from audiences such as this are, what's the biggest concern you have? What's the biggest problem out there? What's the biggest killer? In my opinion, it's stigma. Stigma keeps people from coming forward. Stigma keeps people in the shadows. Stigma keeps people from asking help and from receiving help. And if we can start with stigma and overcoming that, then many other problems out there will start to fall away. I want to make sure we save plenty of time for questions, so I'm going to skip over a lot of my comments. A couple of things that I wanted to highlight are, number one, my advisory that I put out on naloxone about a year ago. These are the two versions of naloxone for take-home. One is injectable, Evzio, and it's that easy to save a life. The other one is an intranasal form. Put it in the nostril and you press. So I have a question for you guys. Raise your hand if you know CPR. All right, look around you. Look how many hands are up. Okay. Raise your hand if you carry naloxone with you everywhere you go. And actually, this is much better than most rooms, but you saw the difference in those hands, right? Now, where are we? We're in inner city Baltimore. It is much more likely all across the country, but especially here, that someone comes in that door right now and says there's a person overdosing out on the street, or there's a person in the bathroom overdosing, than it is that someone's going to come in that room and say there's someone having a heart attack. So look at our comparative ability to be able to respond to those crises that are all around us. I put out my advisory so that everyone understood that they can play a role in saving a life. At least know about naloxone. Consider carrying naloxone with you. The communities that have been able to turn around their overdose rates are the communities that have really saturated the area with naloxone, because we got a lot of doctors and nurses and professional people in this room. How long does it take for a anoxic brain injury to occur? Anyone? 4 to 6 minutes. 4 to 6 minutes. Anyone know an ambulance that can reliably get from point A to point B in 4 to 6 minutes, especially in Baltimore traffic? So we are not going to respond to this opioid overdose epidemic by relying on calling 911. It's not going to dig us out of this hole. We need to make sure naloxone is more widely available. because there's a person dying of an opioid overdose every 11 minutes in this country, and most of them are dying in bathrooms, in bedrooms, in garages, not on the streets, and we need to make sure everyone around them is prepared to respond. Another thing I put out was this Surgeon General's postcard, and Dean MacKenzie mentioned it. And why did I do that? Because another question I get is, whose fault is it that we're having this opioid epidemic? Is it the pharmaceutical company's fault? Is it the doctor's fault? Is it the police officer's fault? Well, the reality is we all have a share of the blame. We all have a share of the blame, and we all can play a role in digging ourselves out of this hole. And these are 5 steps that every American can take to help respond to the opioid overdose epidemic. And I hope you all pay attention in particular to the be safe. Only take opioid medications as prescribed, always store in a secure place, dispose of unused medication properly. Tomorrow is National Prescription Drug Take-Back Day. It's a great day to look through your medicine cabinets, look through your mother's and your father's and your aunts and your uncles' medicine cabinets, because we like to hoard medications as a culture. We just do. Everyone's got leftover antibiotics and leftover opioids and leftover all sorts of things from 6 and 7 and 10 years ago in their medicine cabinets. And guess what? There are kids going around rifling through your medicine cabinets. There are people who come in your house to do extra work. They go through your medicine cabinets. There are babysitters going through your medicine cabinets and diverting those opioids. 80% of people who misuse drugs, misuse opioids, got their first opioid via a prescription, either directly from a physician, but usually from someone else's medicine cabinet. So very important that you all play your role. I want to talk a little bit about the Community Health and Economic Prosperity Initiative that I mentioned earlier. I'm writing a Surgeon General's report on this issue. And the idea behind that is to make the case to businesses and policymakers that investing in health isn't just good for health's sake. Because, again, unfortunately, most people don't prioritize health, and they certainly don't prioritize the kid with a single mom who's working 3 jobs down the street from us right now, especially not at the CEO or CFO level. But we need to help them understand the communities that invest in health, in complete streets, in safe environments, in green spaces, in smoke-free environments, see lower healthcare costs. Healthcare costs are the number 2 expense for most Fortune 500 companies in the United States right now. Lower healthcare costs, see greater productivity, see lower absenteeism. I want to ask you about this small company that I just heard about. Anyone heard of this small company called Amazon? So the big news over the past year was where Amazon was going to put its second headquarters, right? And where did they end up? Crystal City, Virginia. And what folks don't talk about is when you look at U.S. News and World Report's list of 500 healthiest cities in the United States, 4 of those cities surround Crystal City, Virginia. That is not a coincidence. 4 of the top 20 of that entire list of 500 healthiest cities, 4 of the top 20 surround Crystal City, Virginia. And when you actually talk to companies like Amazon, they won't tell you that they moved there because it was a healthier environment, because they haven't made the connection yet. They'll tell you they moved there because it was an educated and healthy workforce. And that's the thing. We need to translate healthy communities into a metric that moves CEOs, CFOs, and policymakers to action. And why is that important? I want to tell you all another quick story about when I was a health officer in Indiana. One of my biggest laments as health officer is that we weren't able to get the tobacco taxes raised in Indiana. We have some of the lowest tobacco taxes in the country, and you all are public health experts. You know, the higher the cost, the fewer the people that smoke. We had 2 hours of experts, people like you all lined up to testify to the legislature about why we needed to raise the tobacco tax. And at the end, we had 15 minutes of testimony from the business community. And who represented the business community? The mom and pop bars, the gas stations, and the casinos. And they actually didn't refute any of our health information. They said, that's all well and good, we don't refute that, but if you raise the tobacco tax, it's going to be bad for business and it's going to be bad for jobs in our state. And you know what happened? The legislature said, we heard equal testimony on the issue, we're going to table it, we're not going to tackle this issue right now. And so I had to ask myself, if I get a chance to go at this again, what do? Do I get more experts? Do I get more of you all in the room? And I'm not diminishing the importance of what you do in the science. But in terms of motivating policymakers to act, what we need are the Amazons. We need the Googles. We need the large corporations to come in and say, look, raising the tobacco tax isn't bad for jobs. It's good for jobs. It's good for business. And so that's the case I'm trying to make in my CHEP report. Another really interesting story, I love stories. I was at the US Conference of Mayors, and Bill de Blasio on one side of me from New York, had Mayor Benjamin on the other side of me, who's the mayor of Columbia, South Carolina, and I asked him, and I had mayors all around me. It was a group like this, and I wanted to know what made them tick. So I said, how many of you all ran for office on a pledge to lower your community's hemoglobin A1C rates by 15%? How many hands do you think were raised? Not a one, not a one. But any one of us in this room would love to go out and say, we've got an intervention that lowers your hemoglobin A1C rates by 15%. That's how we talk. That's our language. But guess what? Mayor Benjamin actually turned Columbia, South Carolina into one of the most walkable cities in the United States, something that we would think is a laudable goal. He didn't do it to lower hemoglobin A1C rates. He did it because when you create walkable communities, safety goes up because there's more foot traffic. There's more light posts. It's a safer environment. Criminal behavior goes down. He did it because property values go up when you create a walkable community. He did it because there's more foot traffic downtown, which increases revenue for businesses. And the businesses do better. And they create more jobs. And there's more tax revenue because more people are spending money in your downtown area. They did it for their reasons, and guess what? It also lowers hemoglobin A1C rates. But we have to, again, think about how we become better communicators, and nothing drove it home to me quite like hearing the mayors talk about why they invest in some of these interventions that we think of as being health promoting, but they think of as being business promoting. I could go on for forever, but I really do want to save some time for questions, so I will stop right there, and I want to make sure we have some time for some dialogue. Thank you very much.
Thank you so much. And that was, you brought up some very important points, especially finishing off in terms of the importance of communication as, public health professionals, as medical professionals, which I think is totally important.
And that's my push for you all, for all of you all, is, again, in this room, when you gather, make sure you have people who are communication specialists in this room. Make sure you have people from the business school in the room. In many cases, they're going to help you articulate your argument to the people that matter in a way that is much different, much better, and in many cases more effective than what we will with our traditional health and medical language.
Right. And I think that there's especially no more important time than now to focus on communication, especially as it relates to the measles crisis, which is currently, blowing out of proportion. Already here in Maryland, we've had, at last count, I believe, 4 cases of measles right here in Baltimore County, the Baltimore County area. So certainly we're seeing the impact even here in our area. And we know that there's a small but very vocal group of individuals who still don't see the benefit and still raise questions in terms of the safety of vaccination. How do we as public health professionals interact and communicate with these individuals to share with them the importance of this as a public health issue?
That could be an hour-long discussion, and I'm going to try to hit some high points in a very short amount of time. Number one, I've seen this evolve because I've been involved in public health and been a state health officer. And 5 years ago, when I was state health officer of Indiana, the folks who were vaccine resistant would show up to the State House every single session with a bill. And there would be literally hundreds of them outside the State House. And even though they represent a minority of folks, the impression that they gave was that it was this giant force of people who were against vaccinations. And so you have to put yourself in the shoes of a policymaker and say, okay, I had to fight my way amongst all these screaming moms to get into the State House. Even if I believe in vaccinations, what do I do? And so a lot of them passed laws, and they'd stand in front of the camera and say, I believe in vaccinations, but I also believe we should give people choice. And that started to erode away at a lot of the success that we've had from a public policy point of view. So one of the things is we need to show up. Because we know that 93% of children out there are vaccinated. So 93% of people believe in this, but it's the same problem public health has. No one wants to show up or talk about it when it's working right. They only want to complain and say what's going on when things go bad. So part of it is showing up. And again, that loops back to my CHEP initiative and my national security initiative. It's about showing people the value of health and public health to them in their daily lives so that they show up when these discussions are happening and so that you aren't hearing from the very vocal minority in many cases. Another important point to remember, again, 93% believe in it, 7% are in that category of not vaccinated. But in that 7%, there are two subcategories. There's what I call vaccine-resistant people. Some people call them the anti-vaxxers, and some people are just vaccine hesitant. There's actually three groups. There's also another group of people like the moms out there who are working 2 and 3 jobs and just can't make it to the doctor's appointment in the hours that are laid out to get their kid vaccinated. So one of the things we need to do is make it easier for people who want to do the right thing to do the right thing. The second thing we need to do is realize that even of that 7%, it's a small minority who are truly vaccine resistant. A lot of folks out there just have questions and they want to have their questions answered. And a 15-minute doctor's visit compared to the hours that they've spent searching the internet is a losing endeavor every single time. So one of the things that I learned they were doing in Washington, in Clark County, when I went out there as a result of the most recent vaccine outbreak or vaccine preventable disease outbreak, is they're having Q&As with the public after hours. And it's a low pressure environment. Folks can come in, they can ask questions. At the end of it, we're not standing there with a needle in our hands, or there's not a needle sitting on the counter with the vaccines in it that you as a parent think are going to kill your kids. And it allows folks to have that conversation so that you can take more of those vaccine hesitant folks and shift them over into the pro-vaccination community. So it's trying to think about how we can have that conversation in a low pressure, more friendly environment and give people more time to ask their questions and to absorb that information. So I think those are some of the key points. The other thing we have to do is help folks understand it's not just about the individual. It's about the community. And so when we were out there, it wasn't just, we had actually a small number of people with measles, but 800 kids missed school in the week that I was out there. Moms who are pregnant are scared to go out shopping because they don't want their babies or their fetuses to be exposed to measles. There's an impact that goes so much beyond. People missing work because of quarantines. You saw the news today. 2 universities out in California are quarantining people. So it's affecting people well beyond just a case of measles. And I don't want to say just a case of measles because we also have to help folks understand that it's more than just a rash, but folks haven't seen measles. And they're still going to be unlikely to actually see a case of measles. So we've got to make it more than just about the individual getting measles. We've got to make it about the impact on the larger community.
Absolutely. Thank you. So we do have questions that have come from the audience as well. Unfortunately, we won't be able to get to all of them. However, I did want to read one question that came from the audience, and this is in relation to climate change. Mm-hmm. What are your thoughts on climate change as a public health issue?
That is a wonderful, wonderful question. And again, I'm going to try to boil a topic that we could talk all day on down into some key points. This, again, is a communications issue. We fight a lot about the science. This comes back to communication. And I'm going to tell you another story that I told at a TED Talk recently. When I grew up as a young person here in Maryland, you'll never believe what my job was. I actually worked in the Southern Maryland tobacco fields. And it wasn't because I didn't know tobacco was dangerous. It wasn't because I didn't personally experience it. My grandfather died from lung cancer, from smoking cigarettes. I had asthma growing up, and secondhand smoke would put me in the hospital like that. It was because the priority in my life, coming from a poor family, was being able to generate income for myself so that I could buy the food on my table and the clothes on my back. And from my point of view, the climate change debate, the science is important, and it's important we continue to evolve the science, but it's really about a policy initiative. And when you go into a community where 80% of the community works for the coal mine, and the grandfather worked for the coal mine, and the great-grandfather worked for the coal mine, and it's the only thing that they know is a way to support their family, and you go in and you say, my goal as a policymaker is to shut down the coal mines, and you don't have any alternative available for them to meet their basic need according to Maslow's hierarchy, they're going to say, well, screw you. That's what they're going to say. And so if we want to have a conversation about climate change, we need to sit down with communities, and we need to start off by saying, can we all agree that we want to have the best world possible for our children, our grandchildren, et cetera? And you start from that place instead of demonizing people. And most people will agree with that. And then we say, well, let's talk about the science and what we can do to improve that community. And let's talk about your concerns about what that means. And give people the opportunity to say, well, I need to generate income. And we also need to very much think about what we're going to substitute in, what that transition looks like, so that folks don't look, because folks, in most cases, if you give them the science and you approach them with compassion, they're going to do the right thing. But if you demonize them, if you tell them the planet's going to be ruined because of your coal mine, and I want to shut down your coal mine, they're going to react the way that you see communities across America react. And so my biggest plea on climate change is, when you're having a conversation about climate change, remember the key word in public policy is public. And you need to sit down with the public. You need to be compassionate. People need to know that you care before they care what you know. You need to figure out what their concerns are, and then figure out how you get there together. And in many cases, the other thing is, and I learned this from a dean of public health in Indiana. He was the health commissioner of Arkansas. And he said, sometimes you need to accept a half a loaf instead of a full loaf. And we also are guilty of trying to go after the full loaf or nothing at all, instead of being willing to compromise. But if you go into communities with compassion, if you're a listener, if you show them that you care before you care what you know, you can start to edge in the right direction. But if you go in there as the arrogant public health official, I know better than you, I'm going to shut down your livelihood because it's the right thing to do for the planet, you're going to lose every time. And that's my opinion, but I think you've seen it play out over and over and over again in public health and public policy debates.
And I think that perfectly ties back into your previous point on communication and being able to listen, as you were talking about, and being receptive to other people's points of view and having that discussion. And I think that's absolutely important as well.
And travel as much as you can, especially to the younger people in here. I've been blessed in my life. It wasn't by intention, it was just by accident. I've lived in Berkeley, California, which is one of the most left-leaning places you can ever live. And I lived in Hamilton County, Indiana, which is the reddest county in one of the 5 reddest states in the entire United States. And in Berkeley, they considered me a staunch conservative. And in Hamilton County, they thought I was a socialist. And I was the same exact person. But until you travel and start to realize how differently people view certain issues, I want to tell you another quick story, and I'm sorry, I want to take questions, but I think this one is important. I actually was in Switzerland, and I was talking to a group of international folks, and they gave me 8 minutes, and they asked me to describe the US healthcare system in 8 minutes. And I said, there's no way I can do that, but I told this story. So when you look at Berlin, Germany, and Paris, France, these are 2 cities that are in 2 different countries. They speak different languages. And during the last great world war that we've experienced, they literally tried to obliterate each other off the planet. That's how different these 2 cultures are. When you look at them, they are more aligned on health issues like access to health care coverage, like women's health, like drug policy, like guns. They're more aligned than Boston, Massachusetts, and Dallas, Texas. But yet, folks expect us to sit in Washington, D.C. and come up with policies that bridge Boston, Massachusetts, and Dallas, Texas. Dallas, Texas, where you can drive around with a shotgun in the back of your pickup truck, and it's perfectly normal. Boston, Massachusetts, where you drive around with a shotgun in the back of your pickup truck, and within 5 minutes, you're surrounded by 20 police cars because someone thinks you're a terrorist about to commit an attack. Very different cultures in our country, and you have to realize that. There's a great publication by Colin Woodward called The 11 American Nations. And I don't have time to go deep into it, but he really breaks down the different areas of our country and their different cultures. And it was life-changing for me as a public health person, because it really crystallized what I'd been seeing throughout my travels in a way that helped me understand I've got to speak to someone in Dallas, Texas differently than I speak to someone in Boston, Massachusetts. when I'm talking about public health. If I'm in Hawaii, I've got to use a different language than if I'm in Arkansas. And I've got to sometimes work with different partners. The faith community is extremely important in the South. You're not going to get anything done without partnering with them. Law enforcement is more important in certain areas of the country. And so you get that through travel, but you also get that through, first of all, acknowledging that not everyone thinks like you do.
And this will have to be our last question. And this also comes from our audience. There's concern that getting prescriptions for naloxone, and I think it was great that you demonstrated how to administer naloxone earlier in your talk, but there's concern that prescriptions for naloxone will potentially increase insurance premiums. Is that a possibility, and how can that be addressed?
That is a concern that was brought up in Massachusetts, and we've worked with the legislators there and the Department of Insurance there, and with the National Association of Insurance Commissioners. And so what they have assured us is that they have taken a look at all of their policies, and in Massachusetts, they actually have made it policy that you can no longer discriminate against someone solely because they purchased naloxone, and that is permeating across the country. So it has been a concern, but we've been assured that across the board now, folks have seen the light, and we are continuing to listen for cases. And I got to tell you, I haven't heard of any cases, any smoking guns recently. We had in the past, but we haven't heard any recently. And so I carry it, and I would encourage you all to carry it. The other thing is, if you're concerned, getting naloxone through prescription is just one way to get naloxone. Baltimore Health Department provides naloxone. There are plenty of nonprofit groups out there that provide naloxone. If you're concerned, then try to get naloxone through other means, or at least become knowledgeable about naloxone so you can talk to other folks. The concern is only when you actually get a prescription for naloxone or get it through a standing order from your pharmacy, and then it goes on your actual record. But again, even when you do that, we've been assured that insurers are no longer doing that. What they're going to do is, if it pings that you got naloxone, then they're going to dig deeper into your record and see if there's anything else that suggests that you have a history of substance use disorder. Because where they're coming from is, if you're getting a prescription for a drug to reverse an opioid overdose, then it suggests that you were at higher risk for an opioid overdose. And so it makes sense where they're coming from, but it's actually how they put the policy into operation in the context of what's going on. And so, fair question. I think the concerns are lessening based on what I'm hearing and based on the actions we've taken, and I would still encourage folks to try to get naloxone.
Thank you so much.
Well, can I tackle one more? And I know I'm late, but I do want to talk about, and I imagine the question would have came, but healthcare. And this is another controversial topic. A lot of folks ask me, what are your feelings on the Affordable Care Act? What are your feelings on Medicaid expansion? This is another communication issue from my point of view. Here's what I say. The Affordable Care Act is a political vehicle, a political means to an end. The end that I care about, that I talk about, is every person deserves access to high quality, affordable health care when they need it. If you start there, instead of starting with, you need to support the Affordable Care Act, or you need to support Medicaid expansion, I think you get a whole lot more people on board. And then you start to work backwards. Interestingly enough, when you look at the red states that utilized the Medicaid expansion funding, they all did it through an 1115 waiver, Medicaid 1115 waiver initially. Why is that? Well, because politically, the Affordable Care Act was such a hot button topic that no one wanted to touch it with a 10-foot pole in a lot of these states. But allowing them to craft their own way of expanding access to care, and in Indiana, we did it through an 1115 waiver in our Healthy Indiana plan, allowed both the politicians and the people of that state to feel like they had some control over it, and it wasn't these bureaucrats from Washington, D.C. standing on high trying to tell them what was best for their state. So I encourage you all, when you're having the conversation, start with the goals, and then realize that there are different political ways to get to that goal, and they're important because at some point we've got to figure out which policy gets us there. But don't get so caught up on the policy that you lose the forest for the trees, particularly when it's a hot button policy. And now that you have so many red states that have access to funds through a waiver, And also be willing to listen to people. In Indiana, folks push back against work requirements. They push back against premiums, et cetera. What I will say is, regardless of how you feel about it, in Indiana, we expanded access to 400,000 people in our state because we came up with a half a loaf plan in many people's minds that actually allowed us to sell it to the politicians and the people in that state. And I say half a loaf not because I believe it was half a loaf. I think it's a great plan, and we actually are getting more people preventative care in Indiana than in many states that just simply expanded Medicaid, because we started to put in incentives and carrots and sticks for people to get preventative care. That was important because you had public health-minded people at the table when we were crafting the plan. But you again need to give states that flexibility, which is what we talk about. You need to let people know that you care before they care that you know. You need to realize that, again, Dallas, Texas, and Boston, Massachusetts are going to be very different, but they all care about protecting the health of the people in their states. So thanks for giving me a little bit of time to go off on that. But it's such an important topic, and it's one where I think we shut down the conversation before the conversation even starts in so many cases, because we make it political right off the bat without even realizing that we're making it political, instead of focusing on the people, the outcomes that we all care about. So thanks so much, Ryan, and thank you all for the opportunity. I appreciate it.
And before Dr. Adams leaves us, we actually have a gift to say thank you so much for being here at Johns Hopkins Bloomberg School of Public Health and our annual J. Douglas Colman Grand Rounds lecture. And I hope that you will appreciate that.
What were you all saying about climate change? Oh, wow.
So he can represent us.
And they got me a nice, it looks like a coffee. Oh, right.
It's a Johns Hopkins Bloomberg School of Public Health mug as well. Thank you so much.
Thank you all. And again, I apologize, but I am literally sprinting out of here because I think the president is waiting on the phone for me and a vaccine conversation we're having, right, Dennis?
Thank you so much. All right, before you all leave, thank you so much for your patience with us. I'd also like to ask for Miss Jane Lamott, if you can join me up front for a second. As we mentioned before, Miss Lamott is the daughter of J. Douglas Colman, who our Grand Rounds lecture is named after. And we'd like to say thank you to you as well for being here. And on behalf of our program, our residency program, we'd like to offer you this gift.
Lovely, thank you
And
so much.
You're so welcome. Thank you so much.
Thank you.
As we close, I'd like to just remind all of you that there is a reception that is actually going to be held in the gallery. So that's right down this hallway to your right as you exit the auditorium. And before you leave, I wish to say thank you to a few select individuals. First of all, I'd like to say thank you to Dottie Beecraft and Barbara Todd, who are the program staff in our residency program, who are very instrumental in pulling all of this together as well. I'd like to thank the Dean's office and Dean MacKenzie. Thank you so much for your support. Dean Sharfstein, who's no longer with us in the room right now, but we wish to thank him as well as the special events team, security, everyone watching live, and all of you. Thank you so much.